Now we hand over the session to the session managers, and they can introduce the next chairpersons for the next session.
Thank you, chairs. Moving ahead, we have second session of the day, and chairpersons for this session are Dr. Navneet Agrawal, who is MD, PhD, and diabetologist practicing at Gwalior. He is head of Chief Diabetologist and Director Diabetes, Obesity and Thyroid Center, Gwalior. He is CEO and founder of DNA Sugar Clinic. He has various awards. He is editor of various journals, and he has published more than 100 papers in national and international journals. I welcome him to chair the session. And second chair for the today is Dr. Catherine Vine. She is professor of endocrinology at Ohio State University. She is director of Adult Type 1 Diabetes Program, Adult CFRD Program, and Diabetes Transition of Care Clinic at OSU East Hospital. She has served on National Board of Directors of AAC and NLA, and she has done various clinical research activities focused on management of type 1 and type 2 diabetes, diabetes technology, NFL NASH, and severe risk in type 1 diabetes. I welcome Catherine for the second session of the day. Over to you, Catherine, and second chairperson.
Thank you so much.
Yeah, over to you, Catherine.
Over to you, Dr. Navneet.
So thank you, Dr. Vineet. With my co-chairperson, Dr. Kathleen, I welcome you all for this Diabetes Technology Conference. And for this session, which is a mixed bag session, we have the wonderful speaker with us, Dr. Juliana Chan, and she'll be speaking on this biogenetics for the precision medicine. And to introduce her, she's a professor, is a clinical scientist. She has graduated from Liverpool University, UK, with various accreditations in endocrinology and clinical pharmacology. She's currently professor of medicine and therapeutics, founding director of the Hong Kong Institute of Diabetes and Obesity. She's the director, Clinical Research Management Office at the Chinese University of Hong Kong. Her major areas of interest include epidemiology, genetics, clinical trials, and care models in diabetes, and a Hong Kong government-funded theme-based research involving a multi-topic analysis of diabetes and its complications for personalized care. In 1995, her team set up the Hong Kong Diabetes Registry for quality improvement and research purposes. In 1997, her team received the Best Hong Kong Hospital Team Award for these initiatives, which provide a reference for diabetes care. In 2007, her team set up the Asia Diabetes Foundation as an university knowledge transfer project to implement a web-based joint Asia Diabetes Evaluation Program to use a structured data collection. Over the years, she has organized many conferences, seminars, workshops, including the Cambridge Diabetes Epidemiology and many more. She is currently a member of the steering committee of the Hong Kong Government Framework for Control and Prevention of Non-Communicable Disease. So welcome, Dr. Juliana Chan, and over to you.
Thank you. So thank you, Dr. Agrawal, and thank you, Dr. Wine. So could you see my slides? Right.
Yes.
Okay.
Yes.
Thank you.
Yes.
So thank you. First, I would like to thank the organizing committee for inviting me to give this talk about biobanking and biogenetics for precision medicine in diabetes. So I'm an endocrinologist and clinical pharmacologist, and as these are my disclosures. And as physician scientists, we make observations all the time during our clinical practice. And I'm sure many of you would agree that diabetes is very complex. Every person with diabetes is unique. And even you have the same person, even you have a twin, depending on the setting and the care, sometimes the outcome can be quite different. And so really the challenge of diabetes management is really redefining the diabetes in order to give sort of more precision in terms of the treatment and spotting the similarities and differences between different individuals with diabetes. And on that, we really need to have some conceptual framework based on our experience and also the evolving knowledge. So the prevention, treatment of diabetes aim at prevention of diabetic complications. We understand that actually diabetes frequency coexists with hypertension, dyslipidemia, and this abnormal internal milieu will activate a lot of the pathways such as aldose reductase, AGE, protein kinase C, etc., and loss of some of the protective pathway. And these can be under both the genetic influence as well as epigenetic influence due to environmental or treatment effects, and this will lead to loss of structure and function and giving rise to all these complications. Within this conceptual framework, there is a strong genetic component in diabetes, and these genetic factors can be rare, can be common, and over the years, we now have a lot of technologies and methodologies, analytical tools to try and help us understand the genetic basis, because understanding genetic basis will obviously give us a very important insight regarding the causes, and with the causes, then we will be able to find either cure or intervention. And of course, people might have monogenic diabetes, and we need to use either trios or family pedigrees to actually discover that. We have the more sort of not so rare variants with larger effect size. Then, of course, the common variants is small effect size. And really, over the last 20 or 30 years, there has been a lot of knowledge again in this field. The other important premise is, of course, we all have a set of DNA codes, and depending on different circumstances, this would then be translated to RNA, to proteins, to our phenotypes. And we actually started with the phenotypes. We'll have to work the way back. And of course, we now know a lot more about the architecture of the genome, all the way from the epigenome to RNA, which can be coding or non-coding, to finally to proteins and metabolomes. And we need to have the phenotypes to match these molecular signature. And along the way, we also need to understand the influence of, for example, treatment that can alter these phenotypes. Finally, and because of that, we understand that in diabetes, there are actually modifiable and non-modifiable factors. So with the genome, really, at the time of conception, this is already being programmed, and depending on the exposure, this will be gradually unfolded, and then depending on our education, our lifestyles, access to care, the outcome can range from anywhere healthy aging to premature morbidity and mortality. So it is against that backdrop that nearly 25 years ago, we started formulating these strategies with 30% of people being obese and 10% of people with diabetes. How do we stratify risk? How do we classify disease? This is very much data-driven. And so how do we use IT to actually enhance prediction, prevention, and personalized care? And where the genetic variants can help us to identify really at-risk individuals, either for diabetes or complications. And in these individuals, we implement behavioral therapy, disease management, and on top of that, really have pathway-specific therapies. So we then embarked upon this journey in 1995, really combining research and practice in order to discover new knowledge to improve precision of diabetes and treatment. And between 1995 till now, there have been multiple milestones. And this is the Hong Kong Diabetes Register, which I'll talk about in a minute, is really the fundamental of this program for both care and also research. And along the way, we have established many cohorts, the Hong Kong Diabetes Register as part of the quality improvement program. We have the family-based cohorts, the community-based cohort, the youth cohorts. And then after 10 years, we ascertain the outcome of a diabetes registry cohorts. And then we developed a lot of equations. We started getting our second youth cohorts and including the mother-child cohorts because we understand the life course of diabetes now. We have our second ascertainment of the outcome in our diabetes register. By then we're also part of the global and Asian consortium for discovery of diabetes genes. And then in 2013, we actually recall, some of the community-based cohorts and family-based cohorts to ascertain the rates of developing diabetes. And in 2014, we established a multi-center Hong Kong Diabetes Biobank. And along the way, we have really applied different methodologies to try and understand the genetic basis of diabetes, initially really using resequencing to identify monogenic diabetes. Then we use linkage analysis to identify chromosomal regions which are linked to diabetes and different traits using family-based cohort. We then focus on candidate genes using SNPs and later on using LD and TAC SNPs to understand genetic variants of some of the candidate genes in terms of predicting outcome. And then we have entered the era in 2000 where we use genome-wide association studies. Of course, now we are using next-generation sequencing for multi-omic analysis. And with this rich databases, we start doing computational and network analysis. And of course, many of you have been part of this web-based J portal, which is really, again, trying to combine some of the protocol and methodology to establish register to actually try and translate and discover new knowledge. So what we did is actually we need to actually transform the clinic setting in order to collect this high quality data, and using a trio team in order to set up the register together with the biobank with the patient's consent. I cannot emphasize enough the importance of structured assessment here, as in accordance to international guideline that these people should have their eye, the feet, the blood, and the urine assessed every year, every 2 years. And then these data can be digitalized and linked to EMR with hospitalization, drug and lab data. And most importantly, to use this data to create personalized report to stratify risk, empower self-management, and identify care gaps. So in 2007, we did our first sensory and start having some idea about the profile of these individuals. Type 1 diabetes is very rare, even in young people. These people are relatively young, but importantly, after 5 years, actually 1 in 3 of these individuals have a major outcome. And apart from cardiovascular disease, we found that actually kidney disease is very important in our locality, and so is cancer. So using this rich database, we developed a lot of risk equations and reported that different attributes could actually predict different outcomes. But among these risk factors, actually EGFR and ACR, representing the internal metabolic milieu for both the vascular and also renal health, a very predictive outcome. In particular, for kidney disease, we found that actually metabolic syndrome, the hypertension and dyslipidemia are also very predictive outcome. So first, to actually test the utility of this biobank, we actually started with really looking at some of the targeted genes. Okay, these genes actually are drug targets, and so one of the most popular one, a common one, that well-known one, is of course the Dti polymorphisms. And in these databases, we were able to confirm that after adjusting for all risk factors, there was a greater relationship between DD, DI, and II carriers on actually end-stage kidney disease. We also found that on top of these genetic risk factors and conventional risk factors, blood pressure and triglyceride are very important. So of course, we know these people should be, really targets for RAS and also RAS inhibitors and MRA. Within the glucose pathway, the aldose reductase is very important. And here again, we ascertained that actually the aldose reductase A is at -2 microsatellite polymorphism, and also polymorphisms in the promoter regions also predict end-stage kidney disease. And some of you might know there is now an aldose reductase inhibitors in phase 3 development, mainly for heart failure. But important to note, these risk factors, common variants are indeed common, and identifying these individuals are important to actually ensure that they might be benefiting from this targeted pathway. PKC is actually an important pathway, and at some stage there was the PKC inhibitors, but this was shelved because of futile results. They were looking at retinopathy, but at least in our hands, using TAC SNPs in this region, we were able to show that people who've got multiple SNPs in this PKC actually have 6 times increased risk of end-stage kidney disease. So apart from this diabetes, and also apart from glucose, and also high blood pressure, and also vascular fats, lipid abnormality is very important. And in order to interpret this data, really understanding pathophysiology is also important. And that's the reason why I think clinicians are so important in actually setting these biobank and databases. We know that visceral fat is a key feature in type 2 diabetes, with increased production of free fatty acid and increased production of glucose and VLDL, and giving us high triglyceride-rich lipoprotein particles together with dietary fats. And then under the influence of different lipases, they will be degraded to IDL, later on LDL, and HDL. But these lipases, as well as these apolipoproteins, can also have a genetic variance. And we were able to show that different variants of these modulators actually associate with the kidney disease. So as we continue to learn from these patients, we noted that 1 in 5 patients actually have young onset diabetes defined at the age of before 40. And actually compared to their late onset counterparts, these people have 50% increased risk of mortality at any age, in part because of the long disease duration and because of the poor glycemic and risk factors control. These people are also very heterogeneous in terms of phenotype. Some of them are obese and some of them are lean, but compared to the type 1 diabetes, the outcome are rated very poor. So to understand this heterogeneity of the young onset diabetes, as I mentioned, we set up the family-based cohort, and then we need to control the youth cohort, the mother-child cohort, as well as really entering into a lot of international collaborations for replication and also for discovery purposes. For example, the Global 1Q Consortium and Global Type 2D Consortium, as well as the Asian Genetic Epidemiology Network. One of the first things that we did is actually, because type 1 diabetes is very rare among our young people, we collaboration with Professor Graham Bell, we actually use resequencing and look at 92 unrelated Chinese subjects, okay, and they have young onset diabetes, strong family history, and discovered that actually 8% of these individuals have novel mutations in HNF1 alpha and glucose kinase genes. Through this epidemiological survey, we also understand that obesity and genetics are actually having more significant roles in autoimmunity in these young people. More recently, we were able to, based on our collections, we actually did auto anti-GAT in our young onset, in our young patients. So in these 1,500 patients with young onset diabetes, we measured anti-GAT. There was 253 patients with classical type 1 diabetes. We found that 8% of these individuals were actually LADA. These LADA patients actually had lower risk of cardiovascular disease, but higher risk of severe hypoglycemia compared to the non-LADA young onset diabetes. But compared to the classical type 1 diabetes, they actually have 3-fold higher risk of end-stage kidney disease, probably because of the silent presentation and probably, delayed intervention. So important to note, among these type 2 diabetic patients, actually these people with LADA are very sensitive to insulin compared to non-LADA, and really identify these patients are important in order to give them the targeted therapy. So LADA and MODY probably only explain about 12 to 15% of young onset diabetes. So using our family-based cohort, we're using microsatellite markers to try identify chromosomal regions which are associated with diabetes traits within the family, for example, chromosome 1, 2, and also 16. But then, we found while we should be really resequencing the genes within this region, comes the GWAS era. So this was the first GWAS that we did in our Chinese patient with familial young onset diabetes. And we found that actually one of these genes, which is DACH1, this is a transcription factor implicated in developmental biology, was associated with young onset diabetes loss of 2.4. This was replicated in the Asians and also in cardiovascular disease. And more recently, we're able to show that DACH1 is actually implicated in islet development. By knocking out the gene in this zebrafish, you could see that the islet was not developed, which was corrected when we actually reversed the gene expression. The second GWAS that we did in these young people was actually PAX4, and this is again a transcription factor which is important in differentiating, in the lineage, the development of progenitor cells to either endocrine or exocrine lineage. And in fact, this again was associated with 18% increased risk of diabetes in the Asian population. And subsequently, it was also reported in a consortium that actually this gene is actually only found in the Asian populations. And so in these people who actually carry these SNPs, actually even in normal individuals, we already see that they have reduced beta cell function in both children and young adults and with hypoglycemia. Over these years, report contributed to the discovery of loci in type 2 diabetes, which is now coming up to 400 in the global population, about 100 in the Asian population, with some of them are being found in Asians and some of them found in Caucasians, although the majority can be replicated in both cohorts, in both the Caucasian and non-Caucasian populations. It's important to note that there are actually different allele position, different effect size, and because of the different LD-BOP among the ethnic groups. So from DNA then to actually RNA. So, these biobanks are very useful. So for example, in these young onset diabetic cohorts, we use their PBMC and then we did transcriptome, and then using, complex analysis, this interactome analysis with replication, we found that we identify hub genes, which actually complement with some of the GWAS signal. In the metabolic surgery, we also identify young people who are obese, obviously either with or without diabetes. So again, using epigenome, we did epigenome analysis and also transcription analysis in their adipose tissue, both the visceral fat as well as the subcutaneous fat. We identify epigenome hubs, which is associated with adiposity in type 2 diabetes, and these hubs are implicated in adipogenesis, inflammation, and insulin signaling. So as the research proceeds, we then actually found there was a declining rate of a declining incidence of cardiovascular disease, but we found that actually cancer became a major unmet need. So more than 10 years ago, we reported the linear relationship between A1C and cancers, and more recently, we have reported the association between glycemic variability. Here you could see the A1C variability score, as well as the glycemic burden. And so that people who have actually got high glycemic variability, particularly in those who are obese, they have actually got increased risk of all sides cancer after adjusting for many risk factors. So here, this is again, something that we need to explore. And indeed, using our biobank, we're able to identify some of the microRNA which can predict the occurrence of liver cancer nearly 6 or 7 years before the occurrence. So raising the possibility that some of these microRNA can be used to identify high-risk individuals for intensive management. So in summary, this when we talk about precision medicine, this is really a very broad subject. And of course, the biobank and the registers help us a lot. But this is not really just about biobanking and also getting registers. It's a lot of understanding of the subjects and how do we translate the evidence to practice. Diabetes is complex, as we know. This is clearly genetic. There are common and rare genetic variants. The demographics, the age, the sex, the socioeconomic factors are very important. There are familial factors such as like hepatitis B, viral infections, thalassemia rate traits, which might also contribute to diabetes development. Of course, the ecosystem, the culture, the psychosocial behavior factors, the microbiota, hormonal and drugs, and access to care can really change a lot of the trajectories. So here, really, we need to redefine diabetes. There are people who are obese, prediabetes, the obese type 2 diabetes, you have the lean type 2 diabetes, some of them may be larger, some of them may be ketosis-prone type 2 diabetes, some of them might have type 3 diabetes because of pancreatic disease, then you have the type 1, the MODY, and so forth. So really structured assessment is critically important, the demographic, the life course, really all the way from birth history, the childhood history, of course, the genotypes and the phenotypes, and this will form the basis for us to organize our precision care. The risk factor control, the self-management are critical, the early intervention based on a wealth of evidence, and then on top of that, maybe we'll be entering an era of risk-based medication using both genotypes and also phenotypes and multi-omic markers. Finally, this is a chronic disease. The regular review is important to engage and empower the individual to evaluate what we are doing and discover new biomarkers, pathways, and targets. So this is really a 20-minute summary of what we've been doing over the last 30 years or so. But I'm pleased to actually report that in a recent review of 16 high-income countries of 0.5 billion people, where there are actually territory-wide or nationwide registers, interestingly, probably because of the reform of the diabetes care, which is very much at the territory-wide level with the data-driven care model, Hong Kong actually had one of the largest decrement in terms of death rates of 4% per year, really dropping from just over 2.5% to 1.3%, 70% decline in terms of the death rates. So I showed you the first picture when I first started. Many of those scientists and our workers have moved on to other institutions and then taking up a senior leadership role. We now have new faces, new fellows, new students, and continue the research. And I really want to say a big thank you to all collaborators, partner, fellows, sponsor, and also patients and their families in making this knowledge discovery and translation possible. Thank you.
Dr. Chan, thank you so much. That was just an amazing overview of everything you've done. Just packed so much information into a short period of time. And I think speaking from the world of diabetes and diabetes research, please keep going. Give us another 20 years.
Yeah, so but luckily I have some really, new blood, young people, energetic people who continue to explore these cohorts. It's been an amazing journey. I think this is really, I hope more groups, and I believe many groups are doing similar things now. I think, we hope more physicians are actually engaged in this kind of knowledge discovery and implementation journey. Yeah. And more research funding can actually support. And of course, not just funding support, but also I think policymakers should create the environment to make this kind of care possible. Currently, care is very fragmented. And then without that kind of setting, it's quite difficult to implement this kind of research and practice. But it is like a chicken and egg situation. We need some champions to start doing it. Thank you very much for your comments.
Thank you. I think now we have to move on, just in the interest of time, move on to Dr. Mader.
Hello, good morning. Sorry, I had just to switch on the light. I'm not at home, so I was not familiar with the lighting conditions.
It's okay. I think we'll just do a brief introduction. Dr. Mader is an associate professor of medicine in the Division of Endocrinology and Diabetology at the Medical University of Graz in Austria. She received her medical degree there at the Medical University of Graz, where she also trained in internal medicine and then endocrinology and diabetology. She subsequently was a visiting professor in Bern, Switzerland, in the Department of Diabetes Endocrinology, Clinical Nutrition and Metabolism. She then returned to Graz, where she leads the Diabetes Technology Research Unit. Professor Mader has done quite a bit of research focusing on diabetes technology with an emphasis on insulin pumps, continuous glucose monitoring, artificial pancreas, and decision support systems for treatment of diabetes. She's published over 90 peer-reviewed scientific papers. She's won quite a few national and international awards in the field of diabetes technology. She also is one of the board members of the Austrian Diabetes Society, where she heads the Diabetes Education Committee and is a member of the Diabetes Technology Committee. She's also, very importantly, has authored and co-authored several national guidelines in this field. She's going to talk to us today about one of our newest pieces of technology that actually not all of us even have access to, which is the smart pens. Dr. Mader, thank you so much for doing this topic.
Thank you very much for the kind invitation. So just hoping that the slides appear. Can you see?
Not yet.
Not yet. No?
Yes, they're there
Okay,
now.
very good. Thank you very much. So smart pens are really the new kid on the block, so to say, and I'm happy to talk to you about this important matter. Here are my disclosures. And all of us know that diabetes management is very challenging. It's a 24/7, 365 job. And sometimes when you're traveling, when you're abroad, when you're meeting friends, it might not be so easy to track all of your activity. And this can sometimes seem like walking on a tightrope, and you want to maybe discuss some of what you have experienced with your HCP, but then data is not there. And we need to track data for all of those injections that we take. So this is for basal insulin, this is for bolus insulin, but we only often don't carry the diary with us around, or we do not want to enter it into our mobile phone app. Additionally, of course, it would be good to track activity and also food intake so that we can make good joint decisions. And data quality, of course, when it's written in a manual way, might not be the best way to assess data. So we have thought when CGM comes around, this might help us. But what I have learned in the early days and still ongoing issue is that people do not really track their insulin doses. So out of 7 days, if I'm lucky, I get 3 or 4. Sometimes I even get less data on insulin. And we have heard before in a very important talk about the importance of continuous glucose monitoring and how to assess this. And here we have very standardized ways to track it, to assess it, to get a picture of it. And I think this would be really very much adjuncted by data on insulin. So we could, for example, add to the ambulatory glucose profile a daily pattern of insulin where we can help us to adjust and better understand diabetes therapy. And so that we do not have to guess what has happened if we do not have those traces, but that we actually know what has happened. And we know that during the COVID pandemic, diabetes technology really helped us a lot because we had access at least to the CGM data, and we could share data with the people living with diabetes and could come back to them and support them without asking them to come to our offices. But of course, having a more holistic picture would help us more. So for connected pens, now that more and more people are using smartphones, data can be transferred wirelessly on insulin doses, including timestamps of the injected dose and also size of the injected dose. And this holistic picture could help us to better understand on both the patient side what is going on, what might have been missed, what could have been improved, and also on the HCP side, how to better adjust therapy, were all insulin injections taken, and not just increase insulin dose by assuming that insulin doses were taken at that time. And one other very important aspect is that we should really reinforce our quest that these data are available also in the electronic medical record of the patient, because only then we have full picture and full access to what is going on. Currently, we do have different approaches. So there is approaches for durable pens, and there is approaches for disposable pens. For the durable pens, we have the direct integration into the pen, and for the disposable pens, it's mostly with caps that are added to the disposable pen to keep track of the injections that were going on. So we also do have different approaches in regard to apps. There are pen-specific apps that directly are related to the app, to the pen. And on the other hand side, we do have general diabetes apps that can be used to add also data on insulin doses here automatically from smart pens. So the first smart pen on the market here in Austria was the Novo Echo, and we do have that pen. Unfortunately, what is not so very common here in our country, and that's one of the hurdles that we are currently facing, is the Gluco app. So especially when we think of people living with type 2 diabetes, this is maybe something they would not consider using that easily. But at least in the offices, we can download the data, for example, using the Gluco app. On the other hand side, there could be the connection with the My Sugar app. Also, this is not widely used in people living with type 2 diabetes, so it's mostly a type 1 product here in my country, which adds again to these hurdles. And if we want to combine it with in the Roche system, we can combine it with the SmartPick software, which is also quite prevalent in the German-speaking market. And then there are other approaches, such as the InPen provided by Medtronic, where we can have different types of insulin. So, of course, for Novo Pen, only Novo insulins are being used. But here, for the InPen, different types of insulins are being used. And what can we see when we use the pen-specific app that is provided? We can see, of course, only if entered the current glucose, but of course the insulin dose that goes in. We do have the active insulin remaining. There is a dose calculator coming around, and people, if they do it, can track the activity. And in the end, we can get reports where we have the full picture of the data. Do those pens help us? I mean, that's of course a very important question. And there was a study done already in 2019 by Manshi et al. And they assessed non-adherence to insulin therapy and if this could be assessed via this Bluetooth-enabled pen. They had the pen used over 1 month, and they had younger as well as older persons living with diabetes. They had to be on 2 or more injections per day. And for clinical assessment, they used continuous glucose monitoring. And with that, they could see that poor glycemic control was associated with less insulin injections taken. And of course, this can then be something to tackle during outpatient clinic visits. Another study that was done just recently in Sweden by Professor Adolfsson was a smart pen study in 12 Swedish clinics. And there they had a pre-baseline assessment and then started the study where people were using the smart pen. They had at least 5 visits, and they also included continuous glucose monitoring, and the smart pen was used for insulin delivery. And what can we see here? We can see, for example, if doses were administered on time when we relate the insulin dose injection to the glucose trace, or if the insulin dose was delayed, so a so-called missed bolus dose, because the trace already shows a trend upwards, and we only see that the insulin dose was taken at a later stage. And of course, also those aspects can then be tackled during the subsequent visits with the patient whenever he or she came to the outpatient clinic. And what could be observed? It could be observed that glycemic control improved, especially time in range improved, and also time in hypoglycemia below 3% decreased, and time in hyperglycemia 3 millimoles decreased, and time in hyperglycemia above 10 also was reduced. What could be the future use? As I mentioned before, and we had already heard this morning, there are metrics for glucose. So why not to standardize also insulin metrics, where we can see the total dose, the basal dose, the pre-meal doses, and the correction doses, and see the distribution over the day, as well as if sufficient amount of doses were taken. So I think the combination of smart insulin pens with new metrics of insulin dosing will be relevant to further improve diabetes care. As we had heard before, current data is frequently incomplete and the information on insulin doses is missing. So now that we have those novel pens around, we hope to tackle this issue. What is still a big hurdle that we do not have, like every pen with an app or people using apps in an adequate way so that we can see actually the data. So this is one of the challenges that we have in the recent times here in Austria. So we have introduced the smart pen 2 months ago, and I think we need to adjust our training strategies, and not just because in my country, so I'm really lucky that we can easily prescribe some of the novel products, but we really also need to alter our pathway, how to then make use of such a pen, because if we just provide this pen without instruction what app to use in combination with it, specifically if it's a pen that comes along without an app, we cannot make the full use of it. But if we do that, we can get a holistic picture and adjust therapy way much better. And what's also maybe a very important part for the future, that the EU now proposed the fair access to and the use of data, because so far companies moved rather to the opposite direction as we had hoped and expected from earlier times when, for example, data from CGMs were easily accessible for various other systems, and now companies start more and more blocking, and the combination of different systems is really getting tricky, and that you do not want to have like one system to show the insulin data, one system to show the glucose data, another system to show the activity level. So it would be really good to come along with an approach where we have access to all data on a specific dedicated platform, potentially the electronic medical record of a country or a region, where all data are combined, and we do not need to look into different software solutions to make things work. So just to wrap up what we have just discussed, diabetes technology as a whole facilitates diabetes management. Smart pens are the next essential tool here. They help to better legibility. We get a timestamp. We can check adherence. Integration into the electronic medical record is key, in my opinion. There should be standardized metrics also on insulin data to complement continuous glucose monitoring data, and access to data should be reinforced so that we do not need to struggle to look into different types of data that we want to assess. And in future, probably with these devices, one could maybe consider or avoid overdosing. For example, if you have like a timestamp on your pen and the pen does not allow to inject insulin when it's not in a relevant after a relevant interval, especially when we consider, for example, once weekly insulin. So this could be one relevant aspect. And what will be probably seen quite soon will be also algorithms that help people who do not want to switch on a pump or who do not have access to a pump and AID system, that they get also better care by using smart pens in combination with algorithm-driven therapy decisions. With that, I'm at the end of my talk and would like to thank you for your attention.
Dr. Mader, thank you so much. I actually wanted to ask you a quick question. When you said you feel that you need to adjust the education you're doing for patients, now that you've gotten to work with them a little bit, could you just for the audience highlight a little bit about what you would suggest people maybe do different from what you did do? But what do you think are the important points as people develop a program to initiate these devices?
So especially if it's like in Austria, where we have now a pen without a specific app. So normally, okay, you get the full package, you have the pen, you have the app, and then you instruct or inform people what to do. But here, now we have the pen and we just switch, for example, the pen without really thinking, why do we give a new pen to that person? And if we just want to kind of exchange a previous pen, I really we encourage people to consider, should it be a smart pen or should it not be a smart pen? So because if we do not do any other training, then there is no use in adding a smart pen to it. If we have a smart pen that we want to provide, then we should say, okay, this app and this app, for example, would be available for combination. Then you need to talk through the advantages of this app, maybe also discuss costs, because currently costs are not really covered. So if it's a full package, then that's easier. For example, like the InPen, when it will be around, that will be easier for reimbursement. But if you have, for example, a system where you don't have a specific app and then you need to pay extra, that might be a challenge. We do hope that in the next month, the Abbott CGM will be available for combinations. I think that will be the next game changer. And then the training will be adjusted to cover for this combination, because this will be probably the most prevalent here for at least the type 2 market in Austria. Mm-hmm. And then you need to really look into the apps and show them what to do, how to install it, and also tell them to provide you access, because that's also one of the challenges, that sometimes you are not allowed to follow the patient. Of course, we don't need to follow them all the time, but at least when they come in for the in-clinic visit, they should be prepared before, so that you don't need to wait for the password and stuff like that to appear.
Mm-hmm. Yeah, we have the InPen, and our InPen app can talk to the Libre, to the Dexcom, and to the Eversense. But what we're really waiting for is a smart pen for the basal insulin. We don't have that yet. And so patients, as you nicely described, have to enter it themselves, and they don't.
Yeah, exactly. So that's a big challenge. So we were all like, oh, wow, now we've got CGM traces, and then you downloaded it, and then you say, okay, well, half the picture now, but not the full.
Yeah, we occasionally have someone who will enter their insulin data into their CGM, but they kind of, after a while, stop. I think they get bored with doing it. So that's why it becomes so important to have these smart pens and getting all the data into one place.
Exactly. I mean, what we instruct for those who are at least trying at some time, we ask them, please do so for the last 2 weeks prior to your in-clinic visit, because then at least we can adjust for that. But yeah, so that was also our historic approach, how to do it when it was still paper-based. and most of them can handle this. But also in the patient's mind, something has changed because they think now everything is automated with the insulin checks. This will come just along with the glucose checks. So that's something we have to really change their approach again. It's maybe a bit better for people who are on AID systems, because for them, they need to enter their carbs to get their boluses. But for people on pen-based therapy, this is something that they just don't have in their focus.
I'd like to ask just one last question. This is coming from our experience. If you had to guess, what percentage of your patients cannot run the apps on their phone? Their phone is too old or whatever.
Well, so I think there will be some people who have that issue. That will be probably mostly those basal insulin users, I would assume, in a sense, and people maybe with less intensified therapies. And pens like the NovoPen can save, as far as I remember, 800 shots of insulin. So if you download that at your facility, that's also an option. But of course, for them, it would be better if they want to know, have I injected my insulin? Didn't I do so? To really track it in a way.
Yeah. Thank you so much.
Thank you. Will we have a joint discussion afterwards also, or is that?
As of now, we can't see any much questions in the chat box, so I don't think we'll have much question answer session after the end of the session.
Okay.
So thank you, Dr. Madad.
Thank you.
And for the next session, I'll be inviting Dr. Chris. Dr. Chris Jacob, are you there? In fact, I think there were some issues. So probably he might not have joined. So I'll request the management team for running the video of Dr. Jyotidev Kesavdev on the same topic of this.
South India. So this is an investigator-initiated trial, and we have received a grant from GenDeal. So for those of you not familiar with GenDeal, what is GenDeal? GenDeal is the only FDA-approved lancer, and this lancer works by the principle of inducing a vacuum. And it not only accelerates the blood, it ensures a very gentle prick, and the vacuum can lift the skin to avoid injury to the underlying pain nerves. So it will prick only the surface capillaries. So that is supposedly the mechanism by which it is either eliminating the pain or reducing the pain of pricking. So these are the components of GenDeal. It has the contact tips as seen in this picture, and there is a nozzle, there is an activation button, you can see the activation button over there, and then there is a plunger, and there is a 3-step simple process for drawing the blood, automatically drawing the blood. And the contact tips comes with different colors, the blue representing the shallowest and the violet representing the deepest depth. So you may be wondering why we are going back to the technologies in an era where there is a penetration by the continuous glucose monitoring devices and by the upcoming non-invasive technologies. We still believe that the conventional glucose meters will still have a life for another 1 to 2 decades. And it is still the gold standard for blood glucose monitoring, especially the structured glucose monitoring. But with conventional glucose monitors, the major limitation or impediment is the pain of monitoring, which is probably much higher than the pain of insulin injections. So this is the aim of a study, a randomized open label interventional crossover trial, comparing the two modalities, GenDeal as a painless lancer compared with the conventional lancets. So this is the broad view of the study design inclusion criteria. Subjects with type 1 and type 2 diabetes aged between an inclusive of 6 and 69 years, hemoglobin A1C of about 8%. So subjects were randomized to either the GenDeal arm or to the conventional arm. And at the end of 12 weeks, they will be switched over to the respective other arms. Very simple design. A total of 110 patients, half of them approximately with type 1 and the other half with type 2 diabetes. Those who were on GenDeal arm, they were provided with butterfly touch lancets. And those who were on conventional device, they were allowed to use their own lancets. For uniformity, we provided the same glucose meter for subjects in both the arms. So what are the primary outcomes of this study? So the primary outcomes were percentage reduction in the hemoglobin A1C, percentage improvement in the blood glucose monitoring adherence, assessment of the pain, improvement in the pain, and then the probability of using these devices in future. And this is with respect to the frequency of monitoring, at least 4-point blood glucose monitoring twice weekly in type 2 diabetes, and a 6-point blood glucose monitoring daily for type 1 diabetes. The phone visits as per the frequency in type 1 and type 2 diabetes, and during every physical visit to the hospital at the end of 12 weeks and at the end of 24 weeks, the study coordinators will be going through closely monitoring the following parameters. Let me now move on to the results. And this is the hemoglobin A1C reduction, the primary outcome. And this is at the top, the overall results from a baseline of 9% down to 8.28%. Reduction in the hemoglobin A1C, and the same statistically significant improvements were noticed in both type 1 and type 2 diabetes. And with respect to improvements in blood glucose monitoring adherence, there was a significant improvement in type 2 diabetes, and overall there is again an improvement, 80.9 versus 64.18%. However, there was no statistically significant improvement in type 1 diabetes. Obviously, there was no improvement. And with respect to pain improvement or pain reduction, those who were on conventional devices, majority of them reported either no change in the pain perception or probably slight worsening in the pain, whereas on Gentile, represented by these green bars, they have admitted that there has been an elimination of pain or significant reduction in the pain. And this is the pain scoring. Again, significant improvement in both type 1 and type 2 diabetes, and with Gentile 66% and with conventional 35% improvement in the pain. So statistically significant and clinically significant improvements in the pain with the new Lancer. And the question on probability of using this device in the future. Both subjects in type 1 and with type 2 diabetes, majority opted for Gentile as an option. If they have given an option, they'll be going for Gentile as a pain-free Lancer. So this is an overview of the results. And in conclusion, this is a study providing evidence on the benefits of Gentile as a vacuum-based Lancer improving self-monitoring frequency and hemoglobin A1C. Reduction in the pain could have contributed to the higher adherence, and the same could have contributed to more frequent lancing, and subsequently could have resulted in improvements in the hemoglobin A1C levels. Thank you very much.
Hello.
Yes, Dr. Noni, the video lecture is over.
Okay.
We still have time, so we can continue the discussion. Dr. Julia
We are left with 4 minutes, so like.
I think we can continue the session till 11:15 probably. There are 15 minutes for discussion in this session.
Okay.
Let me just check it again though. So, if there are any questions,
So, Kathleen, your views on the self-monitoring of blood glucose, if the non-painful or the less painful devices are available, can it make a change in the frequency of monitoring, and it will be more acceptable? Because if we see the kids of type 1 diabetes, those who are taking 4 times, 5 times, or 6 times a day, it becomes painful for them, and many of times in the patients or in the areas where the affordability is a challenge, it adds to the cost of the patient along with the therapy. So if there are some wearable devices or some non-painful devices, can they make a difference?
So I would guess they can make a difference, especially for those who cannot afford continuous glucose monitoring. One of the biggest hurdles for people is really that pain that they do not want to do the finger pricking. So it's rather that they inject the insulin because they know they absolutely need it, versus the finger pricking is in many cases omitted. So if there is a less painful way that really might contribute to better monitoring frequency.
Thank you. Thank you.
Do you think this device is more valuable to pediatrics or adults, or valuable to both? Just speculation.
I would guess it's probably valuable to both. I mean, for kids, if they are in the care of their parents, even if it's painful, they would make sure that finger pricks are performed at least once they are in their care. Of course, they would prefer systems that are less painful also for the children. But I think adolescents are probably the population where finger pricking frequency goes largely down, especially in the time when they are not surrounded by their parents. But in general, it's valuable for all of them, adults and children and adolescents.
Thank you. Thank you. Anything else, like Dr. Juliana, you'd like to say or to give a key message to our audience regarding the precision medicine? Basically, like if we are going for a precision medicine where we are focusing on the medicine particularly to that particular patient. So like if you can give some key message, like which can be applied or which can be helpful in for Indian audience or Indian population.
I think we're at the dawn of precision medicine. I think currently, the ADA is putting together some documents, right? However, I think precision medicine is not just genotypes. I think it is really a holistic management. Really understanding the patient is the first key. And I think this structured assessment, I really personally found it very, very enlightening. It's also very useful to the patients because, that kind of assessment, maybe every 2 years during a 40 years or 50 years of a journey, this is really only about talking about 20 to 40 assessment, but that has to be done properly. And then how do you use that data to try and manage the patient and then stratify risk and power patient management? And then how do we use the technology? And I think now we have so many technologies, medications, pen, it makes it even more important, this kind of assessment. And then I think the genotype or the biobank is really, you sort of use that setting to add value to what you're doing. So knowing the patient, treating them, at the right time for the right reason with the right drug, and then with the right strategy, just doing things right. I think data are very important now. I think it's really nice listening to the smart pen, CGM, right? Because many patients, even with type 2 diabetes, eventually need insulin. And how do we continue to provide feedback so that you're changing the person? I think that message has to go to the patient very early on. It is not just treating a disease, but transforming a person. So I think, you need multiple parties to create a new trend. So like your Diabetes Technology Conference, you are creating a new trend. So your message are reaching out to many, many people so that you've got more people engaged in the field. Then I think we can have a new movement. Because currently, I don't think there are enough people who know enough about diabetes to actually get the new knowledge and translate knowledge. But I think we are now really in a new dawn because the COVID tells us these people are very, very vulnerable, not only for chronic complications, but acute complications. These are the ones who actually can collapse the healthcare system. And what can we do in order to reduce, their vulnerability? Mm-hmm. So that's my little message. Yeah.
Dr. Chan, could I ask you a question related to some of the data you presented? You showed us really interesting information about the GAD positivity in the lean, younger type 2s. And just to ask a couple questions, do you have an estimation either of age or BMI that would prompt you to check? But as a corollary to that, there was a paper in the fall of 2019, a position statement from a European group suggesting that we should actually check GAD65 in all type 1s so that we don't miss these patients.
Yeah, I agree. I think actually, young patients, I think they should have a C-peptide and anti-GAD done. I think the yield is high And as I said, you don't want to miss them, right? You don't really want to treat them with oral drugs, right? And expose them to hyperglycemia. And then 3 years later, then you found that they DKA, for example, or they're put on SGLT2 inhibitors, etc. It's becoming difficult now, really in the old days, it was really lean and young, right? But you can really have people who are overweight, right? And so I think they should be done. And recently, one of my colleagues, Professor Ronald Ma, I think the IDF Atlas, they actually found out that the so-called LADA, right? They actually not just the young people, even in old people. In fact, I think sometimes we have too much preconception. So I think, just calling somebody type 1, type 2 is really too crude. I think this C-peptide, anti-GAT, I think, or maybe even 1 or 2 additional autoimmune markers will at least help us identify those people who need insulin. And then, that the others will need other medications. Yeah.
So we actually do measure 5 antibodies on our patient, all our patients when we test for antibodies. And just this week, we diagnosed a 70-year-old woman who had 4 of the 5 antibodies.
Wow. Yeah.
Yeah. And she just presented with hyperglycemia after surgery. And someone said, you're very slender. We should check your antibodies. 70 years old.
Yeah. And we see different, and we also see some fulminant type 1 diabetes, for example, after, a adenovirus infection. And this was first reported among the Japanese. So some of these are elderly, right, middle-aged. And obviously, they also have other GI problem. And these people actually, they do need insulin, right? So I think those are, and then now we also have, all these immunomodulating therapy, which is also causing autoimmunity. So, and again, maybe these people harbor antibodies, right? They already have that predisposition, HLA type or antibody, and that's kind of unmasked. So I think better phenotyping is very, very important. Yeah, the biomarkers. So actually, I wanted to ask a question, Dr. Mazer, the smart pen, do they actually give reminder? For example, because I found that many patients, they just cannot remember, for example. So they have a alarm clock so that they can, remind them to give prandial insulin, for example.
So for the InPen, I cannot say because we do not have that. The NovoPen Echo does not. So that's what I can say. So that's, of course, an unfortunate aspect. Of course, this would be good. I mean, maybe this can be something companies can consider, but at present, it's not available. Okay. Do you know for the smart pen, for the InPen?
Yeah. So with the InPen, when you set up the app, it actually asks you, do you want to program in your basal insulin dose and timing? And if you program into the app that I'm supposed to take 30 units at 9 p.m., it actually does remind you.
Yeah. I think with so many young people getting diabetes, and I don't know this current COVID, right? Because there are already emerging data suggesting that, the COVID might actually unmask some of these beta cell defects. And so we might be seeing, another way for people with diabetes. And I think it's good that we have so many technology, but I think the system needs to change, right? More focus on the ambulatory care, more focus on data, more focus on multidisciplinary care, and using the data to empower the individual with this ongoing assessment, and ultimately transforming, these people are very high risk. So this was one of the recommendations, or certainly key recommendation that we gave in the Lancet Commission on Diabetes, and the importance of data, which is not just clinical, but also all the biogenetic. Yeah.
What you can also do with such a system, you could, for example, rank patients according to a traffic light system. So who should come in earlier, who can stay out of clinic for like half a year, 9 months, and really make it more patient-centric, who should come in and who does not have current requirements to see the HCP. So this
I fully agree, yeah. Because that's the only way to manage. It's just a complex disease, right? They keep coming back and then they are not fully engaged. I mean, ultimately, the system just, these people are just neglected, or they default, or we miss things, right? So I think having this system, the personal, the doctor, as well as the data system, I think that would be very helpful.
And we in Austria are very unfortunate in terms of data. So countries like Scandinavia, they are way better connected for all patient visits. So they have a very good track. So for us, it's more like on a local level, not a national level. And also that is something that needs to change, because there you cannot see trends, you cannot see like nationwide trends in that sense. And also do not easily have access to which patient receives what type of treatment. So that would be really a big requirement for our country also to improve.
Even in India, we don't have any national registry sort of system. So yes, Dr. Pari.
Yeah, Dr. Nalit, I had a question for Dr. Juliana. This issue was discussed yesterday as well. So when we talk about biobanks and any such system where we are collecting sensitive data of patients, how do we ensure that the data is secured? And how do you win the confidence of patients that it will not be breached?
Okay. So when we first started back in 1995, right, this was really part of this complication screening process. So we applied for the ethics, and then I don't know why I thought about that, right? Because, I thought I was doing the epidemiology. I was really, sort of keeping up with the literature. And then so when I started the register, I already had this plan, right, that's actually the genetics are important. So we got consent from them so that we took that extra to, the EDTA blood and also the serum, right? And then we store it, right? We aliquot them with all the sorts of informed consent. And at that time, we also make it very broad, right? Because we acknowledge, we wrote in our consent form that obviously, you're doing a complication screening. This is for quality assurance. At the same time, we really still don't understand, right? There's a lot of things that we don't understand, and we need to, collect ongoing information. And most of the patients really agree. So then, of course, you do need to have your laboratory, you do need to have your refrigerator, and also the sensing, etc. So we learn as we go along. So, of course, now the whole thing becoming more and more, regulated, whatever, right? You see, and of course, now we have a CU biobank as well. So the institutional are also getting more geared up. Now, of course, the technology is a lot, right? You have the sequencing, and then now you have to, in the consent, you also have to be more broad, right? Because when you do whole genome sequencing, you might discover certain things, right? Then you probably have to revise your consent form and whether the patients want to know, anything which might not be related. So I think that might be, that leads to a bit of thinking when you design, these data bank, biobank.
Yeah, what I mean is that in your case, I know that you did take the consent and all that, but when it grows and, other countries and at other institutes, when we start making biobanks, I think there is a need for some regulatory mechanism by which we can ensure that the data of patients is safe and secured.
Yeah, sure. I think that the identification is very important, right? All these data have to be de-identified, right? So, and then somehow, there might be one or two people who only know the ID to actually link it up with the EMR. The custodian, obviously you need custodian for these databases. They obviously have to be housed, okay? And then also they have to be within a firewall. So this needs to be done within an institution. So for me, of course, I work in a teaching hospital, so I've got those facilities, the infrastructure to help. But I think sometimes a consortium might also be set up, okay, and then to try and link up different clinics to do that. So,
Dr. Julia Mader wanted to add something. She was going to say.
Yeah, I just wanted to say we have one of the largest biobanks or the largest in Austria, I think. And people are quite keen to provide their data, because also here we have a consenting process available. And once they consent, of course, they can withdraw anytime. But all the different departments in our hospital and even the whole hospital system sees that they are part of the biobank. And whenever they come for routine blood draw, their data is taken. And this gives us really a very long-term follow-up of specific cohorts. So in different fields, from surgery, from internal medicine, and this really adds to that data also from pathology. But yeah, so what's still a bit missing is the output from that big biobank. So we have really large collection. Maybe this could be also something to consider for a collaboration for Juliana. So I could establish the contact. So because we have a large database with good clinical data and samples, but maybe not making full use out of it.
Yeah, this is the new frontier. Obviously we started really very early, 1995, right? But I think the technology and the field continues to move, right? And now the technology become more and more affordable. When we first started, really very, very expensive, but we stored the sample. We were starting off with just a clinical database analysis. But I think, characterizing the phenotype become very, very important. And then when it become more affordable and with all the funding, then we were able to start matching some of these genotype data. So we're doing quite a lot of multi-omic analysis. And of course, like what you say, we need collaborators as well, right? Because we need independent validations. So it'd be great to sort of connect up and see whether we can be, one of my colleagues is actually doing a lot with type 1 diabetes as well. So, so are you doing this kind of research also in the type 1 diabetes?
Yes. So we have sampled for all types of diabetes, and also with their medical history and probably some of the family history, and so the medication that they're taking, comorbidities that they have.
It's great, this kind of forum really foster collaboration.
Yeah, I will just drop you my email address into the chat.
Okay, yeah.
And I mean, it's not my main type of work, but I can connect you with the person heading it.
Thank you. That's great. Okay, good.
While you all are exchanging information, if we have time, let me go ahead and give you a question that came in through the chat. And it says, is LADA a variant of type 1 or a separate entity by its own right? And I think it'd be nice to have both of you give us your opinion.
Well, I think certainly from our perspective, actually, we have the sort of LADA, they have a lesser insidious form of presentation, right? And very often some of these actually have residual C-peptide. We probably need to, some of them also have other genetic variants as well. So the titer might not be very high, there's still C-peptide, and then they might have other common genetic variants, but eventually they still progress faster in terms of insulin requirement compared to others. So we're still looking at the HLA type, for example, and then see whether they're different from the classical type 1 diabetes. So I think more research is needed, at least I think in the East Asians. So I don't know, Dr. Lauder, do you see a lot of LADA in your population?
I think we never really got into classifying them very well, but so now that we know a bit more of it, we start reassessing that. So for a long time for us, it has been like, okay, this is kind of just a very late beginning, slow progressing form of type 1 diabetes, and we do not treat it actually so much different to current treatment of type 1 diabetes. But the mindset has changed in the last 1 or 2 years, maybe. So when people got more and more alert about potential different mechanisms. So I think, as you said, more research is needed, and also more clinical attention for diagnosis is needed. In a sense, we are happy that we assess, at least for C-peptide and antibodies, with the first presentation in our outpatient clinic, but not all centers in Austria, and especially not GPs, have access to that. So, for example, if a person comes in at a certain age, they would assume, oh yeah, that's type 2 diabetes because that person is 70, but we have presentations of true type 1 diabetes also at later stages. I think this is something in the mind that we have to change. And that's not even talking about LADA. That's just like really easier distinguishments that we need to pay more attention to.
I would give you a caution on, I mean, I like what you're doing, Dr. Mater, but calling people LADA, I've encountered patients who say, oh, I don't have type 1. I don't need insulin. I don't have type 1. I have LADA. And I'm like, well, you came in with very severe DKA because you didn't take your insulin. So this thing that you say you have LADA doesn't mean you don't need insulin. And that's a problem we've run into, that they think it means you don't need insulin.
In our population, we actually make sure that they have insulin. We explain to them they've actually got antibody that attack the islet cells. And I think, they actually then become more receptive for going on insulin. Because otherwise, without those antibody or C-peptide, they feel they don't have DKA yet, right? But they just poor control. They say, okay, give me more oral drugs, for example. So I think it's really important, right? Having some of these biomarkers to have a more meaningful discussion with your patients, share decisions, and really subtyping these patients are becoming important. I get into a conversation with them now. I said, particularly for these young people, I said, I need to understand, what is your cause, right? Or at least what is the primary cause of your diabetes, and so that I can actually individualize the treatment a bit better. Yeah.
So on behalf of the organizing team of DTCon, I thank you, my co-chairperson, Dr. Kathleen, my speakers, Dr. Julian Wadar, Dr. Juliana Chan, for giving an insightful talks and the discussion. I hope all audience will be benefited with your insights. And thank you very much for being with us. Over to the management team.